Hi everyone, this is Fast Track for Basic Sciences for FRCA. Today I'm going to talk about laparoscopic surgeries. The case history suggests 65-year-old healthy male is awaiting laparoscopic anterior resection. BMI is 35 kg per square meter. What are the potential risks and complications of this laparoscopic technique for anterior resection? There are complications due to positioning of the patient, complications due to surgery, and complications due to creating pneumoperitoneum. What are the positions we use? Trendelenburg position or reverse Trendelenburg position mainly. Complications due to surgery, there may be visceral and vascular damage. Let's talk about the surgical risk. Insertion of the large trocars into the abdomen is usually occurred without direct vision. Therefore, there is potential risk for damage to the solid viscera, bowel, bladder or blood vessels. And also there can be increased risk of formation of retroperitoneal hematomas. Venous gas embolism can occur due to direct insertion of the trocar into the vessel or inadvertent inflation of the solid organ during gas insufflation. The severity depends on the volume of carbon dioxide injected, rate of injection, patient position, type of laparoscopic surgery. Positioning can cause damage to eyes, and there can be pressure points may be pressurized, and there will be pressure ulcers. If we use prolonged Trendelenburg position, there is increased risk of cerebral edema, upper airway edema, which leads to stridor, and FRC will be reduced, VQ mismatch will be worsened, and the ED tube can be migrated into the endobronchial segments. Have you heard about well-leg compartment syndrome? It is due to impaired arterial perfusion to raised lower limbs. This is occurred in prolonged steep Trendelenburg position. The compression of venous vessels by lower limbs supports reduced femoral venous drainage due to pneumoperitoneum. These will cause lower limb pain and ultimately rhabdomyolysis, myoglobin associated acute renal failure. Therefore, we can do some things to prevent this well-leg compartment syndrome. I will talk about this later. Let's talk about reverse Trendelenburg posture. Extreme head-up posture that will reduce venous return will lead to hypotension, myocardial and cerebral ischemia due to low cardiac output. Due to gas insufflation, usually we use carbon dioxide. There will be CO2 dissolution, and that will cause hypercarbia. Hypercarbia will increase systemic vascular resistance, and that will increase blood pressure. Therefore, afterload will be increased. The cardiac output will be reduced due to afterload, and arrhythmias can occur. Let's talk about the creating pneumoperitoneum. When we injected volumes of air into the abdomen, gases into the abdomen, the abdominal compartment pressure is increased and that will reduces the abdominal wall compliance, and intra-abdominal pressure will be increased. High intra-abdominal pressure can cause multiple complications in all the organs. For example, in cardiovascular system, due to the high increased intra-abdominal pressure, systemic vascular resistance is increased due to mechanical compression of the abdominal aorta and production of pneumohumoral factors such as vasopressin, and that will activate renin-angiotensin aldosterone pathway. Compression of the inferior vena cava reduces preload, therefore cardiac output will be reduced and blood pressure will be reduced. Cephalad displacement of the diaphragm will increase the intrathoracic pressure, that will reduce venous return, further reduction in cardiac output and reduce blood pressure. Compression of the pulmonary parenchyma will increase the pulmonary vascular resistance, and therefore again the cardiac output is reduced. In reverse Trendelenburg position, reduce venous return due to venous pooling, and therefore cardiac output will be reduced and hypotension can occur. That will be increased by the high intra-abdominal pressure. Respiratory wise, there will be diaphragmatic exertion and increased intrathoracic pressure, that will reduces the pulmonary compliance. Reduced functional residual capacity will cause pulmonary atelectasis. Altered VQ relationship will cause hypoxemia. Carbon dioxide absorption will increase and increase CO2 in the blood. In splanchnic circulation, when the intra-abdominal pressure is more than 20, there will be reduced blood flow to the kidney and liver. When intra-abdominal pressure is 20, will reduce GFR by 25%. Neurologically, increase in intra-abdominal pressure will increase the intracranial pressure due to reduced cerebral venous drainage. As intrathoracic pressure is increased due to diaphragm pushing towards the thorax. High intracranial pressure will cause cerebral edema, temporal neurological dysfunctions. Let's talk about how to minimize these complications. We can't use laparoscopic surgeries for all patients. We have to fully assess before operation and should consider if there's elevated risk from pneumoperitoneum. We have to discuss with surgical team and probability of conversion to open procedure. We have to discuss with them. We have to use cuff ET tubes to prevent aspiration and dischargement, especially in the Trendelenburg position. We can use pressure control ventilation to minimize peak pressures and have been shown to provide improved alveolar recruitment and oxygenation in laparoscopic surgeries for especially obese patients. Addition of titrated level of PEEP can be used to minimize alveolar de-recruitment, considering the increase in PEEP can compromise the cardiac output. We can use low tidal volumes and high respiratory rate to minimize the peak pressures while maintaining adequate minute ventilation. We have to monitor peak airway pressures throughout the surgery, as there is increased risk of elevated peak airway pressures. If there is hypercarbia, we can hyperventilate and can reduce the carbon dioxide induced side effects. For prolonged surgeries, patients will be returned to the horizontal position at least every 2 hours, and lower limbs are massaged to 5 to 10 minutes before returning to the previous position. That will reduces well leg compartment syndrome. We can use eye covers, gel pads, the pressure points to reduce the pressure ulcers. Carbon dioxide inflation to abdomen should be done gradually at a rate of 4 to 6 liters per minute to a pressure of 10 to 20 mercury millimeter. Pneumoperitoneum is maintained by a constant gas flow of 200 to 400 ml per minute. Continuous monitoring of blood pressure, pulse rate, respiratory rate, EtCO2 should be done, and we have to maintain EtCO2 around 35 to 45 mercury millimeter. That's all for today. Hope you all enjoy. We'll meet again.